Welcome to Dateline Health. This is Fred Libman coming to you from Nova Southeastern University. You know, we're back to a subject matter which we get so many inquiries from you, the viewers. I always say that the three most dominant questions we get are always surgical interventions, and usually they want to know about minimally invasive surgical techniques, which we're going to talk about today, cancer, heart disease. So we're covering two areas. So let me introduce to you two individuals that are very vitally involved with cardiovascular surgical techniques, interventional techniques. So let me introduce to you Dr. Neil Galindez from Florida Medical Center here right in Broward County. Welcome, doctor.
Thank you, sir. It's a pleasure to be here.
Good to have you. And I guess I won't call you an old friend. I'll call you a friend because you're not old. But,
old enough.
Miguel Diaz, otherwise known as Mike Diaz, who is actually the chief of staff at Palmetto General Hospital, which is right on the border of Dade and Broward counties. It's right off of Palmetto Expressway. And he's an interventional cardiologist. Welcome, Mike.
Thank you, Dr. Libman. Good to be here again.
Good to have you. You know, really, the people, the reason they ask about surgical issues all the time is because surgery in the eyes and the minds of a lot of the viewers and I guess the general public is cutting, blood, pain, but you're both in areas where there's been so dramatic a change, so many changes in styles, techniques, and then what you've learned well beyond your training in hospitals and in your residency programs. And I'd like to really get into the tremendous advantages and advances that are involved in cardiovascular surgical techniques. So I'm going to start with you, Dr. Galindez, because you're the cardiothoracic surgeon. And usually when people think of cardiothoracic surgeons, they think of, many, many years ago, having a double, triple, quadruple bypasses and opening the chest and whatever. But let's talk about where you are today in your field.
Thank you. So let me tell you that when I was in training, I did general surgery training first. All my attendings, when I expressed my desire to do cardiac surgery, were saying, "You're crazy. Cardiac surgery is going to be death in a couple of years," right? They didn't know that at that time, the technology and skill set of surgeons were changing dramatically, as you just said. In the last 10, 15 years, we were able to go from full incisions, sternotomy is what we call, where we split the sternum in half to gain access to the middle of the thorax where the heart lives, into now techniques which are minimal invasive that we call small incisions. Smaller incisions either on top of the sternum or on the side, where we can have access to the heart and do things that we need to do, like putting a patient connected to a heart and lung machine so we can do surgery. To the extent we're now working with the interventional cardiologist like Dr. Diaz here, we have developed wire skills that are similar to an interventional cardiologist, and we can work together as a pair, as a single unit in a hybrid room to attend to patients to, let's say, do a valve placement, an aortic valve placement, which before, for a subset of patients with very high risk for surgery, if they needed, let's say, aortic valve surgery, we would say, well, the risk is so high for you, there's nothing else I can do for you, you're going to take your medications and good luck. Now we have, with the availability of new technology and the availability of the specialties and the training of the new surgeons and interventional cardiologists, we can attend to those patients and actually place valves through small incisions or small punctures in the groin.
You know, it's an interesting thing. As you were talking, I was thinking just historically in my own mind about the evolution of of what has happened within the hospital structures. I mean, we talked before the show, Florida Medical Center has been around since the 70s. Palmetto General also around easy to the late 60s, 70s. You know, at Florida Medical Center, it has a history of doing cardiovascular surgical techniques, whereas at Palmetto General, it has evolved into such an important feature of the subspecialty presentation at the institution. So, Dr. Diaz, really, the folks probably ask more today about the issues of stenting and interventional cardiology than any other feature of cardiovascular or cardio care. So let's talk about it.
Sure. So I think, as you mentioned, evolution is probably the key word here. As you know, our therapies that we're able to deliver have changed significantly, and so for the issues of stents and coronary artery disease, we've certainly evolved to the point where we can deliver most treatments transcatheter. So that's kind of the general term we use for procedures that don't require open surgery, transcatheter therapies, and that can range anywhere from putting in stents for people with chest pains to people with heart attacks, or putting in larger devices like valves, as Dr. Galindez mentioned, or clips to treat insufficiency of the mitral valve. So there's a whole range of therapies that we can deliver transcatheter that have probably grown exponentially, I'd say, in the last 5 to 10 years. So there was certainly a steady growth from the 80s when angioplasty first started in the United States to now, where we have a combination of angioplasty and stenting for coronary artery disease and a full gamut of procedures, including structural heart procedures that are all delivered through a transcatheter platform.
You know, it was very interesting. I was just, again, I think on previous shows, and just, I don't know, 3, 4 shows ago, we had some neurosurgical individuals, interventional neurologists, as well as a neurologic surgeon that was sitting here. And we were talking about their new techniques and their new hybrid ORs, which I would like to get into in a few minutes. But they were saying the evolution of what has occurred in cardiology affected their whole training and their whole practice of neurologic surgical techniques, which I thought was very, actually, it was very proper, very professional for them to say it. But the more I thought of it, I realized that, you know, as we transitioned in your field from just surgical technique, open techniques, to doing minimally invasive techniques, and stenting has changed the whole understanding of what capabilities you have professionally.
I agree, and to the point that your neurosurgical guest made last time, interventional cardiologists, we kind of, through curiosity or through boredom or through inability to just sit still, we started to get into all types of vascular beds. So we started purely coronary, but the first carotid angiograms were done by interventional cardiologists. Peripheral angiography, catheter base was pioneered by interventional cardiologists, and I do think that led to you know, it stimulated a desire to deliver transcatheter therapies in different specialties. And so now at Palmetto, for example, we have one of the most active neurointerventional programs probably in all of South Florida, and it's all catheter-based with Dr. Kashal, Dr. Galindez, and his colleagues. Certainly, vascular surgery colleagues have, I think, developed transcatheter therapy as well for peripheral arterial disease. So the concept of open bypasses for peripheral arterial disease, I think, is much less common, because transcatheter therapy has developed so much. So I do think that part of that at least is true, but certainly there's no doubt that each specialist has developed the space independently, but with, I think, a little bit of a push from our community.
Well, that push is the success of the operative procedure and the outcomes. both of you are doing techniques that enables them to do that. I mean, it's oversimplistic to say it, but it's a reality. Dr. Galindez, you mentioned the types of operative suites that are now available. That again is new to not necessarily your institution, but or to Palmetto, but it is new as it's going across the country. People, they're not, you don't have a suite just for this or just for that procedure or this procedure. They are collaborative, and you explain to the people what they are.
It is a relatively new concept, but the hybrid rooms are specific suites where more than one specialty can work with a patient. With the advent of new technology and working together with electrophysiologists and interventional cardiologists, we have the need to have the capabilities of a interventional suite, a electrophysiology suite, and at the same time convert that suite into an OR if we need to. And that's where the hybrid term comes from. So, for example, when we do the transcatheter approach to replace an aortic valve, the patient has to be in the hybrid suite because there is special x-rays, special machines, special monitors that we have to be looking at when we're deploying those valves. And if, for whatever reason, we need to do an open procedure, then we have to have the capabilities and the equipment available to be able to go into the chest and do whatever we need to do. So yes, it is a relatively new concept, but more and more hospitals across the nation are opening up hybrid rooms. And not just for cardiac surgery and interventional cardiology, but for many other specialties.
No, I mean, again, referring to the neurointerventional folks and the neurosurgeon that was here, they also spoke about their hybrid suite. And I think it's very important because I think, I mean, just as an observer, and really what you hear from the people who view, there's a lot more collaborative, a lot more communication between the subspecialties and really almost even down to the, I shouldn't say down to, up to the primary care individuals that come along, because that way nobody says, well, I know what I'm doing and I don't need you. And I'm being very blunt about it, but the reality is that we all need one another in situations such as this. I mean, that's the way it is.
That's correct. And what you're mentioning is something that, a term that has come up recently as the heart team approach. And when we see patients, when someone needs, let's say, a valve to be replaced because the valve is very calcific, it has calcium around it, and is very close, and it doesn't open well, and is giving that patient symptoms. That patient is going to be seen by different specialties, by cardiac surgery to see if they're candidates for an open procedure or a transcatheter procedure, by interventional cardiology for the same reason, by a radiologist. And we all get together in a room and talk about that case in detail and come up with the best approach and best option treatment for that patient. That's what we call the heart team approach. And that's what we do in our different specialties. So it's not just the decision of one physician. Maybe 20 years ago, the surgeon would say, this is what needs to be done, or the cardiologist said, this is what needs to be done. Now, we come together as a team and give our opinion, and after studying the case, we gave the best option for that, for a treatment for that patient.
Well, Dr. Michael Diaz, otherwise known as Mike Diaz, the institution that you're working in has really evolved dramatically over the last, I guess, 8 to 10 years. And I mean, before they even have the privilege through the, I guess, the regulatory process to do open heart surgery. So it's gone from, we'll just do open heart and do what we have to do, to now doing what Dr. Galindez has just explained. It must be exciting to you professionally.
Tremendously so. I mean, I think that we're just really at the infancy stage right now. We're just on the cusp of what probably lays ahead if we consider some of the statistics you mentioned about how elderly the population in Florida is getting and how patients are living with chronic disease longer. And a lot of these diseases, as Dr. Galindez mentioned before, were untreatable, and now we're getting to the point where we can treat them. I think the number of patients that we're going to be able to take care of probably in the next decade is going to grow exponentially. And so we've mentioned a little bit about TAVR, which is the transcatheter replacement of the aortic valve. There's now very good evidence that's been published that even patients who are traditionally considered low risk for surgery do as well or better with the transcatheter therapy. And 70% of the aortic valve replacements in this country are in low-risk patients. So,
really?
So a huge swath of the population will now be open potentially to that procedure. We have a procedure that we're going to be starting soon at Palmetto Hospital called the Watchman device, which is a way to mechanically treat atrial fibrillation. So atrial fibrillation is the most common arrhythmia in the United States above the age of 65. The incidence in patients over the age of 70 is upwards of 10–15%. And the way that's normally been treated has been with blood thinners in order to prevent stroke. Blood thinners carry their own risk, obviously, of bleeding, sometimes catastrophic bleeding. And so the Watchman device provides the opportunity to place a plug, essentially, in the heart, in the area of the heart. It's called the left atrial appendage. It's the area of the heart where most clots originate from, where most of the strokes are caused by. And if you can put this device in there, you can mechanically seal it, and you can help prevent stroke in the future. So it's becoming a very attractive option for patients who can't tolerate blood thinners, or for patients whose lifestyle doesn't really make blood thinners a very good option. And so our colleagues, our surgical colleagues, have been doing this for years. When they go into the OR to do an open surgery, they will ligate the appendage. Dr. Galindez can talk a little bit more about that. But now we have a way to do it transcatheter, which is that phrase that keeps coming up, transcatheter therapy. And so we're very excited about that we're going to be starting soon at Palmetto. We're also doing the transcatheter mitral repair, which is known as the mitral clip.
Explain that to the audience.
So mitral regurgitation, also known as mitral insufficiency, is when the mitral valve is leaking, is not functioning properly, and so it can lead to a lot of patient symptoms: shortness of breath, heart failure, fluid in the lungs, swollen legs, and many hospitalizations and eventually death. So the way that traditionally this is treated is with surgery. The mitral valve can be repaired. And this is part of what our surgical colleagues now are oftentimes doing with a minimally invasive approach, which has been very helpful to patients, particularly when it comes to recovery times and to pain and length of stay in the hospital and all of those parameters. But there are a subset of patients that are, as Dr. Galindez mentioned, too risky for surgery. And previously, if they could not be operated because their risk of traditional surgery was too great, they were offered palliative treatment, medical therapy, and eventually hospice. And so now we have the opportunity in these patients to offer them a transcatheter treatment. So we essentially get, using a catheter-based approach, we get to the valve and we place a clip which helps to approximate the two leaflets of the valve together so that they don't leak nearly as much. It's based on a surgical technique called the Alfieri stitch, which was developed years ago by an Italian surgeon who would sometimes during surgery see a leaky mitral valve and just place one stitch to approximate the two leaflets, and it would help without having to go through the process of an entire surgery to repair or replace the valve. And so that kind of was the original idea for developing the transcatheter therapy of the mitral clip. And so we do that at Palmetto as well. And again, a recent indication has been gained for that as well, which includes a very large number of patients with something called functional mitral regurgitation. And again, 70% of the mitral regurgitation in this country is functional. So these transcatheter therapies, through the data that we've been able to show and the outcomes in very large trials involving lots of patients, we continue to gain more and more indications for their use. And as you mentioned, given the population we have here in South Florida, the number of patients we're going to be able to reach and be able to treat with these therapies is, I think we're just on the cusp.
You know, you have two experts here. You got a cardiothoracic surgeon, you got an interventional cardiologist here, who are talking about ways in which they could prevent you from dying and have a better life. But a lot of it depends upon you. So, Dr. Galindez?
Yes, it is really, really important for people to understand and know some of the signs and symptoms of cardiovascular disease. As you mentioned, somebody could be just walking out on the street, and because of the lack of awareness, they will not go see the doctor when they're experiencing, let's say, a little dizziness once in a while, or a little palpitations here and there. And that could be, those could be signs of something important. For example, if you take a look at the CDC website and look for atrial fibrillation, this is one of the most common arrhythmias that we treat, either cardiologists or cardiac surgeons. And this is the heart has 4 chambers, 2 chambers on the top, 2 chambers on the bottom. The chambers on the top are going to, instead of contracting normally, they're going to be quivering. That's atrial fibrillation. If you take a look at the CDC website, you can see the number of hospitalizations per year. And Florida has one of the highest numbers of hospitalizations due to atrial fibrillation in the country. Okay, there's a lot of people out there that are working with atrial fibrillation. They don't know it. Now, what's important to know about is signs and symptoms like fatigue, dizziness, palpitations, sometimes shortness of breath, fluttering on the chest. If you knew that, if the person knows that, then they're going to seek help, and hopefully they're going to be diagnosed with atrial fibrillation or with something else, right? But if you don't do it, we know that atrial fibrillation, patients with atrial fibrillation are at higher risk, 5 times more than the regular population of having strokes. Dr. Mike Diaz alluded to this by one of the procedures that he does, which is the Watchman device, which is the plug in the left atrial appendage. We know that someone with atrial fibrillation are more prone to have strokes, and the strokes caused by atrial fibrillation tend to do worse than any other strokes. So by protecting these patients with that kind of device, that is a transcatheter platform, again, putting a little plug on that appendage, you're protecting a lot better a patient against a stroke. And these are for patients with atrial fibrillation. What we do as surgeons, and talking more about the hybrid techniques, there is a hybrid approach called convergent procedure. The surgeon does a minimally invasive incision just below where the ribs meet to gain access to the pericardium and inside the pericardial sac, which is a fibrous tissue around the heart, to look at the heart and do a ablation of the posterior wall of the left atrium. We know that most of the atrial fibrillation nidus, or the abnormal impulses, are coming from there, from the left side. Most of it, also from the right side, but mostly from the left side. When the surgeon does this, they're able to ablate a large portion of that tissue. At the same time, an electrophysiology in the hybrid suite comes in. They do a 3D reconstruction of the left atrium, and with a more traditional catheter-based approach, they close the gaps and ablate the gaps that the surgeon could not get, because the heart sits in the thorax in certain positions, and there are certain barriers, natural barriers. So what I cannot get with my approach, the electrophysiology can get, and we get a much better approach. So that's one of the ways we collaborate with other specialties. And then we can send that patient, let's say, to Dr. Mike Diaz, to occlude the left atrial appendage to even minimize or to lower even more the risk of having a stroke.
Well, we got so much to talk about, but we're down to the last 2 minutes of the show. So, Dr. Michael Diaz, I want to say to both of you, I sit here in wonderment. I've been around, and but I'm very proud of the fact that both of you have offered to the public the idea that we have collaborative care today, which I think is very important. But just in the last minute and a half of the show, and I know it's tough, but that's the way it goes, just tell the folks, you know, that they got to get their checkups, please, so that they can get, get to you.
I think it all starts with that. I saw a lady right before I came here in the hospital who had atrial fibrillation and she wasn't aware of it. She was discovered because she went to her primary care doctor yesterday. Good. And had to come to the hospital because she had a very hard rate. So certainly, very unfortunately, we often take care of patients when things are in dire straits, when they have severe symptoms and they end up in the hospital ill. So if we prefer to take care of patients in a preventive manner, when they're in the office, when we can have easy conversations about these diseases and how they could impact their life. So I think that everyone should be seeing their doctor once a year, and when you have particular risk factors, you should be seeing your cardiologist once a year for the right type of preventive care.
Thank you. I want to thank both of you for being here. I know we could do another 2 hours just on this subject, but I wanted to focus on, like I said, the viewers continually talk about interventional procedures, minimally invasive techniques, and I couldn't think of a better subject area to talk about other than the area we talked about today. So thank you very, very much for being here. Dr. Neil Galindez, you're at Florida Medical Center. You're a cardiothoracic surgeon.
That's correct.
With a lot of knowledge. And Michael Diaz, otherwise known as Miguel Diaz, who is the Chief of Staff, by the way, at Palmetto General. Thank you very much for not only your knowledge, but both of you are tremendous advocates. I mean, I could tell. And to me, advocates are the blessed people on the earth. So thank you both for being here today.
Thank you.
Folks, I hope that you paid heed to what you heard. I know a lot of it needs a little, I guess, thought process. But what both of these doctors are telling you is you've got to take good care of yourself. I say that all the time. So don't put off those doctor's appointments. Get those blood tests. Get what the doctor wants you to do. If they want to send you to a cardiologist or whatever it is, just do it. Because your life is under your control, not necessarily under their control when they do their miraculous work, which I think is miraculous. So thank you both for being here. Thank you folks for showing up again and allowing us to come into your home. Remember, this program is called Dateline Health. We come to you from Nova Southeastern University. There's a telephone number and address right here if you need to contact us. My name is Fred Lippman. Until next time, see ya.